Typhoid fever is a systemic bacterial infection caused by bacteria of the genus Salmonella. The diagnosis can be challenging because the symptoms are not always specific and may resemble those of other infections. This is why it is essential to consider this disease whenever a patient presents with a prolonged fever lasting several days without an obvious cause, accompanied by digestive disturbances such as diarrhea, constipation, or abdominal pain, and sometimes neurological symptoms such as extreme fatigue, confusion, or slowed mental responses. The clinical course of typhoid fever unfolds in several phases, each with distinct characteristics. The incubation phase is generally silent, meaning it does not present with obvious symptoms. It lasts approximately 10 days after infection. In some patients, transient diarrhea may be observed, but this is not systematic. This is a period during which the bacteria are already present in the body but without significant clinical manifestations. The invasion phase, or the first septenary, generally corresponds to the first week of the illness. This phase is marked by the gradual appearance of symptoms, which are often misleading at the beginning because they are non-specific. Fever is constant and progressively rising. It increases little by little each day, often reaching 40 degrees Celsius around the 7th day. A pulse temperature dissociation is observed. Normally, when the temperature rises, the heart rate or pulse accelerates. In typhoid fever, the pulse remains relatively slow compared to the fever, which is a typical but not always present sign. Other general symptoms include extreme fatigue, also called asthenia, loss of appetite or anorexia, and general malaise. Patients may also experience nausea, constipation rather than diarrhea, which is often counterintuitive, and abdominal pain, particularly in the right lower quadrant. Frequently present neurological signs are frontal headaches, sleep disturbances like insomnia, and sometimes dizziness. Other possible signs like spontaneous nosebleeds, also called epistaxis. During this phase, the physical exam is often unremarkable, but certain findings may guide the diagnosis. As we said before, pulse temperature dissociation may be noted. A coated tongue, or sabral tongue, meaning it is covered with a dirty whitish coating, often centrally with red edges. The abdomen may be distended with gas and tender, especially in the right iliac fossa, where intestinal gurgling may sometimes be heard. Mild splenomegaly, which is a slight enlargement of the spleen, may be present. Although inconsistent, it is a valuable sign. It should be noted that in some cases, the disease may start abruptly with intense digestive symptoms resembling gastroenteritis. This can delay diagnosis if typhoid fever is not considered. The established phase, or the second septenary, corresponds to the second week of the disease. At this stage, clinical signs become much more pronounced, making the presentation more characteristic and aiding in diagnosis. Fever remains high, often around 40 degrees Celsius, and persists without significant fluctuations. Pulse temperature dissociation is still present, a fairly typical sign. Despite the high fever, the pulse remains relatively slow, which is unusual in other infections. The patient may enter a state of typhus, marked prostration. They are very fatigued, often drowsy, and minimally responsive to their surroundings. Obnubilation and mental confusion may also be observed. A very suggestive sign is inversion of the sleep-wake cycle. The patient is sleepy during the day and insomniac at night, reflecting central nervous system involvement by the bacterial toxin. Diarrhea becomes more frequent and takes on a very characteristic appearance described as melon juice. It is liquid, greenish, and not strongly odorous. These diarrheas are often accompanied by diffuse abdominal pain. On clinical examination, splenomegaly becomes more evident on palpation. The right iliac fossa remains gurgling to touch, reflecting increased or disorganized intestinal activity, and in approximately 25% of cases, lenticular pink macules, a small rounded pink spot resembling lentils, may appear on the flanks or chest. These are characteristic skin lesions, but are not always present. More rarely, an ulceration may be observed on the interior pillars of the soft palate, a sign known as Diget's angina. Although uncommon, this sign can strengthen clinical suspicion when present. Other lenticular skin spots may also appear, though they are infrequent. Paraclinical tests are essential to confirm the diagnosis of typhoid fever, especially when clinical signs are non-specific. Before performing specific tests, certain blood analyses may suggest the presence of typhoid infection, leukoneutropenia, or a decrease in white blood cells, particularly neutrophils, which is unusual for a bacterial infection. The erythrocyte sedimentation rate may be low, while CRP, C-reactive protein, is elevated. Hepatic cytolysis with increased liver enzymes. LDH or lactate dehydrogenase may also be elevated, indicating cellular distress. During the invasion phase, blood culture is essential as it is positive in over 90% of cases if performed before any antibiotic therapy. It allows direct identification of Salmonella Typhi. At this stage, serodiagnosis and stool cultures are generally negative because the body has not yet produced sufficient antibodies and the bacteria have not yet been shed in the stool. During the established phase, the Widal and Felix tests are used to detect specific antibodies in the blood. These include anti-O antibodies against the bacterial surface antigens and anti-H antibodies against the flagella. These antibodies generally appear from the second week of illness. Anti-O antibodies disappear within 2 to 3 months, making them a good marker of recent infection. Anti-H antibodies can persist for several years, making their interpretation more difficult. But be careful, false positives are possible, especially in other diseases such as non-typhoidal salmonellosis, yersiniosis, malaria, brucellosis. Stool cultures or coprocultures become positive later in the course of the disease, often after the start of intestinal bacterial shedding. Blood cultures at this stage may still be positive but less consistently than at the beginning of the illness. Thanks for watching until the end, and don't forget to like and subscribe for more videos.